Hi guys, welcome back. So today is hopefully going to be a quick video on diuretics. So we've got loop diuretics, diuretics, thiazide diuretics, so all sorts of diuretics. Just before we start, the biggest thing about diuretics is that they should be taken in the morning. Diuretics, they make you go to the toilet. You don't want to wake up in the night after you've taken the tablet and constantly needing to go to the loo. So diuretics, the biggest message in this video is that they should be taken in the morning, preferably if, for example, if you're going to take a once daily dose, preferably before 12. We'll first start off talking about the main groups of diuretics. So you've got loop diuretics and thiazide diuretics. So we'll start off with loop first. With loop, you've got quite a few drugs such as bumetanide, furosemide, and a drug that I actually learnt during pre-reg was toracamide. Haven't heard of that before. But bumetanide, out of all those drugs, tends to be the most potent. But when you're actually comparing loop diuretics with thiazide diuretics, loop diuretics do tend to be more potent overall as a group in comparison to thiazide diuretics. So in regards to how loops work, we'll just quickly go over the structure of the loop of Henle and the tubules. So you start off with the proximal convoluted tubule, then moving on to the loop of Henle, you've got the descending loop of Henle to the ascending loop of Henle, and then you're moving on to the distal convoluted tubule. Now, loop diuretics actually act on the ascending loop of Henle, and you're going to need to know how long it takes for them to kick in and how long their duration of action is. So for loop diuretics, it takes up to 1 hour for them to kick in, but their duration of action takes up to 6 hours. It's actually really important for you guys to learn that, because you will find people actually do query diuretics quite a lot because it makes you go to the toilet quite often. So I actually had someone come in today. They wanted to know a bit of information about furosemide because someone they knew I had started on it. A really short course though, because they had a bit of ankle swelling. But unfortunately they had a few scans that were coming up and they didn't really know whether to stop taking that tablet for the day. But after realising what time the scan was and what time they usually take their medications, then it was actually okay, because I remembered that it takes 6 hours for the furosemide to completely get out of the system. So by the time they had the scan, they would be perfect, good to go. So everything was okay. So just make sure you remember those two numbers. Now, in regards to the side effects that you can get from loop diuretics, the biggest one is ototoxicity. So it's all to do with the ears, and the loop diuretic that tends to cause this or has the highest risk of causing this is furosemide. Then you've got things like acute urinary retention. That sort of thing needs to be cautioned in people that have benign prostatic hyperplasia. So their prostate's basically enlarged, prevents them from going to the toilet. So you really don't want to sort of take loop diuretics for a really long time because of that potential side effect that might occur. Now, in regards to electrolytes, so the two electrolyte imbalances that they cause is hyperglycemia and hyperuricemia. Uricemia basically being increased uric acid levels in the blood. It also causes hyponatremia, hypokalemia, magnesia, and also low calcium levels as well. Those are the biggest sort of electrolyte imbalances that you need to remember. And then you've got thiazide diuretics / thiazide-like diuretic. So probably the main thiazide diuretic that you're going to come across is actually benzoflumetazide. So the biggest thing with benzoflumetazide to remember is that it increases the risk of causing gout, because it increases the risk of uric acid levels being increased in the blood. So thiazide diuretics, they act on the distal convoluted tubule, and they take 1 to 2 hours to kick in, but their duration of action can last from 12 to 24 hours. So that is a very long time. They also increase the risk of increasing your LDL levels in your body, as well as your triglyceride levels. So those are two things that you need to be aware of. What we said in loop diuretics was that it causes hyperglycemia and hyperuricemia. However, in thiazide diuretics, it also causes that. That group of drugs also cause that. So they also cause hyperglycemia and hyperuricemia. When you're comparing loop diuretics to thiazide diuretics actually, so the likelihood of them causing hyperglycemia and hyperuricemia is higher when you're comparing it to loop diuretic. You need to make sure you remember those, because you might come across questions that might ask you which one of these drugs increases the risk of causing hypoglycemia the most. So all of them might cause hypoglycemia, for example, but you need to make sure you know which one causes the most. So just remember the whole loop diuretics versus thiazide diuretics with hypoglycemia, for example. Now, in regards to the other electrolytes, so you know how I previously said loop diuretics cause hypocalcemia, hypokalemia, hypomagnesia, etc., etc. So thiazide diuretics cause as well hyponatremia, hypomagnesia, hypokalemia, but the only difference is that they cause hypercalcemia. So that's the difference between the loop diuretics. Now, another thing is renal function. So let's say someone had heart failure, for example, and diuretics tend to be used in heart failure. So let's say they looked at someone's renal function and their renal function was really, really bad. They can see creatinine clearance being really bad, EGFR being really bad, then they've got urea creatinine in their blood and everything like that. Everything was looking really, really bad. In that circumstance, loop diuretics would be preferred over thiazide diuretics, because loop diuretics can be used in someone who has poor renal function, whereas thiazide diuretics can only be used if someone has good renal function, except from one drug. That drug is called metolazone. Metolazone? I think I've pronounced it correctly. I'm not quite sure. As long as you guys understand, fingers crossed. So metolazone can be used if the EGFR is less than 30. So that's the only one. Other than that, all the thiazide-like diuretics, thiazide-related diuretics, they are ineffective if the EGFR is less than 30. If the EGFR is less than 30 though, you can still use metolazone. Now, just two small little things as well to add on. First, with the loop diuretics, I've seen a few questions where they've been like, when can the last dose be given? Loop diuretics, the ones that I've seen, they tend to be once daily, but you can get twice daily. So if someone is on a twice daily dose, the last dose should be given by 4 p.m. Moving back to thiazide diuretics, benzoylfumethazide, you probably see two strengths, 2.5 milligrams or 5 milligrams. So the 2.5 milligrams tends to be used in blood pressure. So that strength tends to be used in blood pressure, whereas the 5 milligrams you will see in someone who has heart failure. So make sure you know the difference between those two strengths. Now, just to give you guys a little bit more information about specific drugs, as you guys probably know, you've got thiazide diuretics and thiazide-like diuretics. So we've spoken about thiazide diuretics, you've got the benzoylfumethazide, but the thiazide-like diuretics are things like clortalidone. So clortalidone, it has a long half-life. So diuretics, obviously, as I said, it's gonna make you go to the toilet constantly, probably, especially thiazide diuretics, considering they work for 12 to 24 hours. But because clortalidone has got a long half-life, it can be given on alternate days. So that is an option for people who don't like the side effect of diuretics. Indapamide, it's less aggravating on diabetes. So do you remember when I said it causes hyperglycemia? So indapamide, in comparison to all the other drugs, affects the glucose levels less. Now moving on to other groups, so you've got potassium sparing diuretics. Potassium sparing diuretics are things like amiloride. So amiloride is one, potassium sparing diuretics in the name. It causes hyperkalemia. You've also got aldosterone antagonists. So aldosterone antagonists are things like spironolactone or eplerenone. So they both cause hyperkalemia. Spironolactone tends to be used in ascites liver failure. I hope I've said ascites correct. I think it's ascites. I think that's how you pronounce it. And eplerenone tends to be used in heart failure, specifically after someone's had a myocardial infarction, so after someone's had a heart attack, so post-acute MI. Then you have got carbonic anhydrase inhibitors. The most common drugs is acetazolamide. Acetazolamide has actually got quite a few uses, so it can be used in glaucoma, or it can be used in things like prophylaxis of mountain sickness. You'll also probably come across eye drops that end in a similar way to acetazolamide. So you've got brinzolamide or dorzolamide, so those are used in glaucoma as well. And then last but not least, you have got osmotic diuretic, so mannitol. Mannitol tends to be used in cerebral edema when there's an increase in pressure in the brain. So the last part of the video, we're just going to quickly talk about potassium sparing diuretics and aldosterone antagonists. So firstly, with the potassium sparing diuretics, so things like amiloride, potassium sparing diuretics preferably shouldn't be taken at the same time as things that also cause hyperkalemia. So things like ACE and ARBs, or even heparins. Heparins cause hyperkalemia as well. Another thing about potassium sparing diuretics is that sometimes they're used in conjunction with other drugs. So the biggest one that I can think of right now is digoxin. Once we move on to digoxin, we'll obviously go over the side effects, the signs of toxicity, the ranges to remember, but the biggest thing to remember now for digoxin is that it causes hypokalemia. That's why on prescriptions you might see that digoxin has been prescribed alongside something like amiloride or spironolactone or something like that, because that causes hyperkalemia, so it prevents the hypokalemia from happening. So moving on to the aldosterone antagonists such as spironolactone, so they don't just have hyperkalemia as a side effect. So the other side effects that you need to be aware of are things like change in libido. Also, they cause hyponatremia. They cause increase in hair growth. They also cause gynecomastia, and they also cause increase in uric acid levels in the blood. So those are other side effects that you also need to be aware of. The last thing is the MHRA warning that you'll probably find in the BNF for this chapter, and it's to do with aldosterone antagonists and ACE/ARBs in heart failure. So once we get into heart failure, hopefully I'll be able to explain to you guys what the first line, second line and things are. But for now, what you guys, just to understand what I'm about to say, what you guys need to know is that aldosterone antagonists and ACE/ARBs tend to be used in heart failure. But after doing the hypertension video and after what I've just taught you now, they both cause hyperkalemia. So in heart failure, the risk of hyperkalemia is extremely high. So the MHR warning in the BNF basically says to monitor the patient and make sure it doesn't get too high, otherwise there's going to be problems and the patient will probably start experiencing symptoms of hyperkalemia, such as things like chest pain or palpitations. That is all for diuretics. Hopefully this was a quick video for you guys to listen through. Hopefully you understand everything that I've said. As I've said before, please like, subscribe and comment if you have any questions, and I will see you guys very soon.